Welcome, everyone. It's morning here, but I know this is all over the world. So, good afternoon, good evening, wherever else you may be. This is a huge honor of mine. So, first of all, thank you to Orbis. Thank you to Cybersight. I'm early in my career, but I feel I do have some things to share, and that's why I'm here. So, thank you all for listening. Thank you to Andy Chen. Thank you to Lauren Sika. Thank you to Dr. Hunter Cherwick and Ibrahim, who was formerly at Volk, and all of the team at Volk as well, for bringing this opportunity to me as well. So we're going to be talking about vitrectomy, and I say it's mostly about the view because, as you know, there's a lot that goes into vitrectomy. It's not just the view, but it is mostly about the view, and I say that because you can't see. If you can't see, you can't operate. Period. Right. We know that from all types of different types of surgery. Anterior and posterior segment surgeons know this alike, that you have to have great visualization for great surgery. So it all starts with the visualization. So I say it's mostly about the view. Of course, there's so much more to vitrectomy. So first, let's jump into some polling questions. I want to get a sense of our audience. So if we can go ahead and queue up the first one, which says, have you personally ever used a viewing system for vitrectomy? And I mean any type. It could be a contact lens, a wide angle system, could be an older system, a newer system. Just want to see what our audience has experience with. We'll have a series of 3 questions here. So that's just the first. Oh, perfect. So this is good. We have about half of the audience that has used some type of viewing system for vitrectomy, and then more than half that has not. So that's good. We have learning opportunities, and then we have experience here to ask some good questions. Let's queue up question 2. So which of these types of viewing systems are you familiar with? Non-contact wide angle, contact wide angle, non-contact macular viewing lens, contact macular lens, all of them, or you've not heard of any of these, and that's why you're here. Thank you for everyone who's participating, by the way, and engaging with these polls. It really does shed some light on the topic. Okay, so we're saying about the majority have either no experience or have some experience with non-contact wide angle systems, which that doesn't surprise me. That's the most popular system in the world. And then there's contact wide angle lenses, which are gaining less and less popularity over time, and the non-contact macular lenses are more than contact macular lenses. That's a little bit of a surprise to me. So we'll go through these. We can queue question 3. This is sort of just a quiz type of question instead of gaining the insights here. So what does air in the vitreous do to the view of the retina? Does it magnify the view? Does it obscure your view completely? Does it give you a wider angle of view, or does it not really have any effect? So we've got a pretty even split between among the 3 options, which is magnifies, obscures, or makes a wider angle of view. So let's keep this in the back of our mind as we go through the slides, and that will become way more evident. Okay. So why should you listen to this? Well, first of all, because you signed up and you're here. So that's number 1 reason. Number 2 is to gain some insights into the retina surgery world. And then 3, of course, understanding that viewing the retina is the most important part of retina surgery. Just as I said, if you can't see, you can't operate. Now, I say that, but are there exceptions? So think to yourself, do you jump into a situation surgically where you just don't have a view? And I can think to myself, of course. I mean, the view, of course, is the most important thing. But of course, there are certain situations where you don't have an option. If I've got complete and total vitreous hemorrhage, hyphema, endophthalmitis, et cetera, it doesn't mean I'm not going to operate. In fact, that is the reason to operate. Right? The patient's coming to you with hand motion, light perception, vision, and they can't see. And that's why you're going in there. But you may not have an idea other than an ultrasound B scan of what might be going on in the posterior segment, or for an anterior segment surgeon with a total, obscuration of view by hyphema or by endophthalmitis. You don't know what's back there. You don't know, but you still go in. and you do the best you can with your view. So there are exceptions to the rule, but of course, barring those exceptions, viewing is very important. And then also understanding that retinal viewing is complex, very complex. That's probably the hardest part of retina surgery. It is what we train on. For us in the US, it's 2-year fellowship after 4 years of residency. So I did my 2-year fellowship, and a lot of that was learning how to view simply. And then we're also going to learn about what's on the horizon. So that's another reason to listen to this. So is this talk important? I mean, we just talked about why you should listen, but should you listen for any particular importance? Of course, yes, I'm biased. That's why I'm giving this talk. But we also have to take a 30,000-foot view of what is going on here. What we're doing is sight-saving and sight-restoring surgery. This is happening every day all over the world to restore sight in individuals. And the gravity of that is so powerful, right? I just was corresponding with a surgeon this morning about his transition from hospital-based surgery to ambulatory surgery into office-based surgery, and talked about a doctor who came to him who just lost vision from a vitreous hemorrhage due to diabetic retinopathy. And because of advances in anesthesia and advances in techniques, this gentleman walked out of the office with vision. And this was a guy who could not go back to work because he couldn't see out of an eye. I mean, this is the gravity of what we do. It's very important. This is our mission. So surgery needs innovation. That's the other important part of this talk is, okay, we're shedding light on all these amazing things that we do and how complex it is, but we shouldn't want it to be complex. We want more ease. We want more affordability to these systems. They're very expensive systems a lot of times. And that's a barrier. It's not just a barrier to affordability and certain community clinic setups, but it's also a barrier to training, to getting new physicians, new surgeons out there. It's a barrier to training. You can't see, you can't teach how to see what you're seeing, and it's hard to share that. And also, of course, we need to make surgeries better, quicker, more efficient, and viewing is part of that. So what are we going to talk about? We're going to first jump into what is vitrectomy surgery, because it would be silly to jump into this without even having a context. So we're going to talk about vitrectomy. We'll talk about wide angle versus macular viewing, contact versus non-contact, reusable versus single use. To me, those seem self-explanatory, but to explain it a bit more, so wide angle meaning more view, right? A wider field of view. And the macular viewing being a more zoomed in view of the central retina. Contact versus non-contact meaning, are we in contact with the surface of the eye, the cornea, or are we hovering above? Reusable versus single use. So reusable being, from case to case, we can clean, sterilize, and reuse. Single use being we open up a brand new product every time. And then we talked about what's on the horizon as part of this talk, and can we do it better? So who am I? I am a cataract and retina surgeon, so I'm a little bit less popular in the US than it is in the rest of the world to do both ends of the eye, but I do. And I did this straight out of fellowship. I went to Yale for my 2-year retina fellowship. I did residency at University of Florida. I myself am born and raised in Florida. Now I practice in Connecticut, and I'm coming to you live from New York, where I live. I'm just about 45 minutes north of Manhattan. And my kind of claim to fame is I have pioneered office-based retina surgery. So this is a new space to do surgery. It's not the hospital, it's not the surgery center, it's in your own office. And we're showing that we can do complex surgeries. And we'll touch on this in the slide later on, because as you can tell, I'm very passionate about where I think the future of retina surgery is going, which is into the office. And I say I'm pioneering it, but really I'm standing on the shoulders of people who have done this with complex surgery and procedures before me in other fields. So we're taking plays from them and learning from it. I founded my own clinic about 5.5 years ago, right out of fellowship, and been fortunate enough to grow and have this innovation experience in my own practice. Uh, and then my last point there is just another personal point about me is I was a college baseball athlete, not so much an athlete anymore, but that is part of who I am. But why am I qualified to talk about it? So first of all, most importantly, is I'm passionate about this topic. I'm passionate about retina, very much a tech guy. Um, this is more than just a surgical field to me. This is a profession, it's a calling, and that leads me to want to investigate and learn more and share with you. I do perform vitrectomy surgeries every week. I do anywhere from a handful to as many as 10 to 15 per week for various reasons. I'm involved in many retina projects, so helping develop vitrectomy systems, the machine itself, viewing systems, technology that will go into future retina surgery, different products. And actually, right now, a little shout out to my team at Yale. We are working on a way to improve the retinal surgery viewing system, and we're very close to developing, hopefully, a prototype within this year. So, what is vitrectomy? So the first point I want to touch on here is never be embarrassed to ask the obvious question. This is more philosophical than it is about vitrectomy, but this is a lesson to myself as well. Oftentimes, we're scientists, we're in the medical field, we're obviously very motivated and very smart, but it's tough sometimes to ask the question that might give the other person the insight that you don't actually know anything about this, and that's okay. That's the learning part of this. So in this situation, if we were all talking and we were in person and you didn't know what vitrectomy was, ask the obvious question: what exactly is vitrectomy? Right? Because then we can work on learning together. But if you don't even know what that is, then I haven't done my job to shed light on this topic before getting into the details. So strictly speaking, vitrectomy is vitreous removal. We all know where vitreous is. Vitreous is inside the eye. It's attached to the optic nerve, the macula, the vitreous base. It's collagen and water, and it is there as a vestigial organ. It's there since we're born. Vitrectomy is removal of that, and then you can do the other things that come with it, the retinal part of it. So loosely, vitrectomy is the umbrella term used to describe many types of retina surgeries. So that kind of seems counterintuitive, right? Why are we calling it vitrectomy if we're really doing surgery on the retina? We're doing a membrane peel, or we're doing a retinal detachment surgery. Why is it called vitrectomy? Why not call it retinectomy? Well, you can't call it retinectomy because the ectomy part is removal. So we don't want to remove the retina. So we can't call it retinectomy. So I guess the field has never figured out a very good way to call it by its retina name. Instead, we call it vitrectomy or vitreoretinal surgery. So at least we have the retina part in vitreoretinal surgery. So that's what vitrectomy is. And there are many types of vitrectomy. So these are just a few of them. And I do all of these. So we're talking about vitreous floaters, debris, veils, strands, membranes. I would put those all into one category. Those are all basically floating opacities that are visually significant to the patient. Vitreous hemorrhage, an epiretinal membrane peel, or otherwise termed macular pucker. Macular hole, submacular hemorrhage, vitreomacular traction, that's causing symptoms for the patient, such as metamorphopsia. Intraocular foreign bodies. So I just removed a nail a couple months ago from someone's vitreous cavity that was sitting on the retina, and I did that in the office. Retinal detachments, endophthalmitis we talked about at the beginning, retained lens fragments after cataract surgery or after trauma, retinopathy of prematurity, diabetic traction, persistent diabetic macular edema, malignant glaucoma, vitreous biopsies for questioning if there's lymphoma or any other oncologic features, and then dropped IOLs, and the list goes on. So what is the technique to do a vitrectomy? So typically we go pars plana approach. Most of retina surgeons are doing a pars plana approach, and the reason why is because that is an entry point into the eye where, God willing, we're not going to hit vital structures. So when we enter into the pars plana region, we're about 3 to 4 millimeters behind the limbus. We've avoided the ciliary body, the ciliary processes. We've avoided the zonules, hopefully avoided the back of the lens. And also, more importantly, is we're avoiding the retina, right? So the retina should hopefully kick in after oris serrata, maybe about 5-6 millimeters back. So we have this small window of opportunity to enter the eye in a place where we're not going to damage any vital structures. So that's why we go pars plana. Technically speaking, what surgery we are doing, modern day retina surgery, is transconjunctival, minimally invasive, valved 3-port, small gauge vitrectomy. But that's a mouthful, so we're not going to call it that. We just call it pars plana vitrectomy. That's why you hear this PPV thrown around or pars plana vitrectomy thrown around, because it's too much to say that we're going transconjunctival, meaning modern retina surgery, we do not resect back the conjunctiva. We just go straight through. And minimally invasive. And then these ports nowadays have valves on them. So they're one-way valves that allow entry into the eye and do not allow exit of fluid. So that maintains pressure. And small gauge coming in 23, 25, or 27 gauge sizes. I do mostly 25 gauge. I think probably 23 and 25 is the most popular worldwide, and 27 as the technology on strengthening the instruments gains, I think that will gain more share as well. So do only retina surgeons do vitrectomy? Clearly not. Now, here is an anterior segment surgeon. This is a typical scenario that we have all been in, and we don't like to admit it, but of course it happens. That's surgery, that's life, is where we can break capsule. And if we break posterior capsule, there's vitreous behind there. And sometimes that comes forward. So as anterior segment surgeons, we've all been trained to deal with that. And one of the ways to deal with prolapse vitreous is you have to do vitrectomy. So actually, you guys do know how to do a vitrectomy. That's anterior vitrectomy, right? Whether it's with a vitrector instrument or whether it's vitreous that is prolapsing out of the wound that you have to manually incise. That's a technique that we all know as well, that if vitreous makes it not only to the wound, but out of the wound, we learn how to cut that, right? Because you have to sever the attachments. And why do we do that? If you've never stopped to think about it, right now is the time. We have an opportunity to really reflect on why do we do the things that we do. So if vitreous prolapses out of the wound, take a Wexel, we grab it, we take manual scissors, we're cutting it. Are we just doing this so it's not in the anterior chamber, so that we don't have vitreous interfering with the vision, or is there more to it? Well, that vitreous goes somewhere. And we talked about its main attachments, right? It's attached at the optic nerve, it's attached at the macula, it's attached at the vitreous base. And there are other, obviously, the rest of the retina, it's attached until later on in life we undergo posterior vitreous detachment. So we care about relieving traction on the vitreous, cutting it and incising it, because it's attached somewhere else on the other end, and that might be the retina. And if you don't relieve that force, that tractional pull, then it may pull the retina off. And so if you just left vitreous in the anterior chamber after a prolapse during a broken capsule case, it's not just that it's going to interfere with the eye well or the vision, it's that you're putting this patient at risk for a retinal detachment. So we have to relieve that traction. It doesn't guarantee that they're not going to develop a retinal detachment or retinal tear, but it dramatically reduces the risk if you can relieve the traction. So here in this video, a pause to shout out to Cataract Coach. If you've not familiarized yourself with his website or his YouTube videos, please do. This is the best way to learn, is to learn from other people and to learn from excellent teachers, and he's an excellent teacher. He's got videos on everything cataract related, and I've just looked up anterior vitrectomy, found one of many videos he had posted, and here's a valuable learning lesson of someone that handled it very well. So let's talk about the first visualization method. The first visualization method is what we just watched. It's direct viewing, right? So that doesn't require a lens. So we don't have to put in a contact lens, a wide-angle viewing system. We don't have to get complex. We can just directly view with the microscope, right? And what can we view with that? So you can actually view quite a bit. you can definitely see your vitreous at the wound, if it's prolapsing out of the wound. You can definitely see if it's in the anterior chamber. And you can see into the anterior vitreous cortex. So if you focus with your pedal down through the iris plane, down past the capsule, and keep going deeper and deeper and deeper, you can view a good amount of vitreous. You can sometimes even get into the mid-vitreous, depending on your scope. So here is a case where obviously I'm going to the macular lens there, but before that, I had taken a pause to clear out some of the posterior capsular opacification behind an IOL here before proceeding with the rest of my surgery. And I'm direct viewing here. So I'm just taking my vitrector behind the IOL, cleaning up the posterior capsule so that I don't have to have that obstruct my view. So that's the first visualization method, is direct viewing. Now, why are there other visual? If we can directly view, why would there be other visualization methods? Well, we need two specific visualization methods. We need a high mag and we need a low mag. And under low mag, we don't just want low mag, we also want a wide field of view. So if we view directly and we put a contact lens on the right side here, that's your macular view. That is all you can get. Maybe you can extend it out to, and we'll talk about strategies here where maybe you can extend that view out to 40 degrees, 45 degrees at the most. It's just the optics of the eye are going to prevent you from seeing beyond that. If your nodal point or your focal point lies way in front of the lens and it lies at the corneal surface, then you don't get a wide angle field of view. So you can't see in the peripheral retina unless you attach a mirror or some angled lens, which is how it used to be done. Is that was the only way, is attach some type of mirror to see far onto the periphery. So we need another visualization method, which is the wide angle field of view. And here you can see the nodal point where the focal plane lies is different than a direct macular view, right? There it has to lie inside the eye, and because, and this picture depicts it very well, because of that, it has to flip the image. So we're going to talk about how reversal of the image factors into wide angle viewing, but you can see a lot more this way. And of course, by doing so, you minify the image. So you get a wider field of view, but you make a smaller image. So here's an example. Here's a real world example. These are not surgical views, but you're about to see that. These are taken from fundus cameras. So on the left is a Optos view, same patient. You know that patient. That patient is on your screen. That's me. So that's an Optos photo, and you can see what a wide angle field of view looks so different from a macular field of view. So the macula gives you the zoomed in view of optic nerve blood vessels in the macula and the fovea itself. And then the wide angle field of view gives you a better view of the mid periphery. And then with dynamic viewing, meaning you move the image, you can start seeing into the periphery. So here's real world, left being a wide angle view and right being the macular view. And if I am correct, I believe this is the same patient. I think I put the same patient here to illustrate the example, but you can see here, there's way more zoomed in view, way more detail on the right, which is great. But then that doesn't work so well for wide angle needs, such as clearing vitreous from the vitreous base, which is what you're watching happen on the left, taking care of retinal detachments. Okay, so this sounds relatively simple, right? We've got wide angle viewing systems, we've got macular viewing systems. Can't be that complicated, right? These are just some of the options that exist. So my point in showing this is that there is so much to retinal surgery viewing, and these are just a handful of selection of products that exist to help us see better. We're going to go over some of those. So, but why is it so complicated? Why are there so many systems out there? So wide angle systems, they can come in many flavors. right? They can be, we talked about contact versus non-contact. They can touch the surface of the eye or not touch it, float above it. If it's a contact system, it can be held by an assistant. Oftentimes you have to have something or someone holding it because that contact lens will just fall. It'll just fall to the side if it's not stabilized. Or you use a sutured lens ring to hold in place. So if you don't have an assistant and you're operating solo, you got to hold that lens in place. Then you put a lens ring on, which you suture to the eye, or hold it in place with the speculum. Or there are many other ways to do this as well. I'm not touching on all of them. Non-contact systems usually held by the microscope, so it floats above the eye with a microscope, or a wrist rest, or to the bed itself. And then there are different materials for wide-angle viewing, different index of refractions, different lens designs, different fields of view. There's single-use versus multi-use systems. So that's why it's so complicated, because there's so many options. And then for macular viewing, same thing. It can be attached to a non-contact system, but most commonly, as you guys answered in your polling questions, that there's a contact. You just put the contact lens on, and that's the most common way to do it. And those can come in different materials too, like glass, PMMA, silicone ring to stabilize versus stabilizing feet, plano versus biconvex versus biconcave, basically minification, magnification. So let's jump into non-contact wide-angle systems. This one is the most popular. This was what you answered in the polling question, is something you're the most familiar with. So probably you've seen or heard of one of these systems. These are, again, not all, this is not an exhaustive list, but these are most of the ones that you'll come across in different operating rooms, different countries. I myself use a Zeiss ReSight. I have trained on an Octopus Biome. I've used a Volk Merlin. I have not had personal experience with the other ones, but there's a TopCon system called Office. There's the Ocular Landers wide angle viewing system. The Hogstrite has a system, and Leica does as well. Basically, anyone who wants to play in this market and has a microscope to attach it to, they usually have a wide angle system. So there's a lot of options out there. And these are some of them. So on the left, that would be a Biome system. And then in the center, that's the ReSight system that I use. On the very right is that Volk Merlin system. Just a few of the ones. Why I use the ReSight, I just want to touch on it quickly, is I think it's got a clever way about how to control the angle of view compared to the other systems. So if we go back here, most of these other systems, if you go to the very bottom of the image where the lenses are floating, that's how you control the view and the focus, is by moving that lens. And the Zeiss ReSight system does not involve movement of that lens. That's fixed, actually. That arm that you see coming down, it doesn't change the distance of that lens from the microscope. What does change is there's a reducing lens inside of the microscope that changes, and that effectively changes the focal point. So that means that all the internal mechanics of the microscope act to bring the image into focus, which I prefer rather than messing around with the outside of the external environment. So the main concept, though, which is similar to all viewing systems, not just the ReSight, is that you have to have this floating, high-powered, condensing objective lens. That's that yellow lens you see floating here, the other ones in the other image that float above the eye. Usually they're very high-powered, so they're above 100 diopters. Because they're so high-powered and because they sit above the eye, they flip the image. Now, the concept here is we need to get as close to the cornea as we can, but not so close that we're touching, not so close that it fogs from temperature difference of the room being cold versus the eye being relatively warm. So balancing that is a challenge. You know, we have, as clinicians, and for those of us that are not retina surgeons, that aren't as familiar with this, you actually are familiar with this world. when you are examining at the slit lamp and you're using a 78 or a 90 diopter or 60 diopter, whatever slit lamp lens you're using to view the retina, it's the exact same concept. You're floating in front of the cornea. It's a high-powered lens, and it is flipping your image. That's why you have to invert in your mind or when you draw. Now, there's contact wide-angle systems as well, way less popular than the non-contact systems, but rewind through the decades, this was the way to view the retina. So this is not like a fringe way of doing retina surgery. This used to be the way. Here you can see in this picture that the surgeon is requiring an assistant to hold the contact. So what I'm pointing at with the red arrow there is the left hand of the assistant is holding the handle of the lens on the eye. And if you've been there before, you know how frustrating this can be. As a resident, this was my job with my chairman, to stabilize the image with my wrist and make sure that I followed whichever way he was going. So if he was going out to the periphery, I needed to tilt the lens to follow him out to the periphery. So this adds a new layer of complexity. So that's very difficult. One of the original lenses for this was the AVI lens, the AVI. And now we have Volk and Ocular Instruments and all these other players in that space as well. It gives you, interestingly enough, it gives you some of the best viewing that you can ever see. And that's because when you're in contact with the eye, you neutralize any effect of the cornea. So corneal astigmatism is neutralized. You're coupled to the surface. You don't have to worry about surface drying. You can actually get around opacities in the cornea, opacities in the lens. And it gives you a wider field of view. Stabilization, as I said, is the most difficult issue. So stabilizing that, in this case, the left hand of that assistant, it's hard. It looks like he's floating without even using the wrist rest. And this does usually require a larger pupil to get a good field of view versus non-contact systems. A lot of times you can shoot through a smaller pupil. Is there such a thing as a contact wide-angle system where you don't have to have an assistant? Because that would be a real breakthrough. Now, Volk has just come up with this lens that I've had a chance, and I'm going to show you in the next slide, a view through that lens that I think is game-changing in a lot of ways. This is a beautiful lens. It's got self-stabilizing feet. The most important part about this is it's light. It's light. It's narrow enough so that your instruments to the left and right of this lens can actually slip in and out of the eye. You can manipulate without knocking this lens over. A lot of other contact lenses are wide and big and bulky and heavy. So this does not require suturing, doesn't require lens ring. You could do this without an assistant. And this is the view through, it's a very wide field of view. So you can see way out to the periphery with this lens. It's a beautiful system. Now, what about, where does the microscope fit into all of this? Can we just do this with any system, any microscope, anywhere in the world? Unfortunately, that's not the case. Most microscopes, you can fit a wide-angle viewing system on, but not all of them. And that's where the complexity of this comes in. So when I say there are things to improve, this is one of the things that has to be addressed is compatibility, universal compatibility. Here's an example. So I used to operate at a surgery center before I moved into my office for surgery. And here's a typical combined case, anterior and posterior segment, that I would have to have set up for me, or sometimes rearrange the pedals myself because it was so complicated for the staff. But look at this. This is 5 different pedals. Obviously one for phaco, one for vitrectomy, sure. But then I have a separate laser pedal, a separate scope pedal, a separate inverter for the system. There's an attachment to the microscope to allow the wide-angle viewing system, allow the inversion. That is complex. And retrofitting this onto an older scope, if you want automatic inversion, because that wide-angle system is going to flip the image and you need to reflip it, otherwise you're operating backwards and inverted. That's a lot to ask. And in certain situations in certain countries where you may not have access to all this, that may be a barrier to doing retina surgery in a high fidelity manner. You can't do it with the comfort of having a flipped image because you can't put an automatic inverter in. That's a problem. So that's something we have to address. And of course, adding a wide angle viewing system, you saw them in that previous picture. They're uh, very tall. So they add a lot of working distance to the microscope, which is tough for surgeons who are shorter or have a shorter midsection, and you have to kind of crane your neck to view through the oculars to get a good view. It's not ideal. So there's definitely room to improve there. So what about that inverted image issue that we've just been talking about? So one way around it. So the question is, well, if wide angle viewing does it, then is that enough? And I would say that's not enough because we just talked about it can be more expensive. It's complicated. It requires automation. Can we do this through a direct image system? And this paper in 2021 showed that there is a way to do it with air bubbles. And I've always thought the same thing, which is air has a different index of refraction than water. Air is about 1, close to 1.0. And water, saline, aqueous, etc., is around 1.3. Vitreous is a little bit more. Silicone is 1.4. IOL is around 1.4. So can we use that change in index of refraction to our advantage? And they showed in this paper that if you use an air bubble with a direct viewing system, so I put a contact lens on, not a wide angle contact lens, but a regular macular contact or flat contact lens, and then I use an air bubble underneath the posterior capsule or put that air bubble into the anterior chamber, you can get a wider field of view. So going back to our polling question, air can be utilized to give a wider field of view. And here's just an example of fluid versus air. So on the right is air, on the left is fluid. One of the ways you can tell here is on the left of the light pipe, which is on the far left of the image under fluid, is giving a shimmery view in the fluid. On the right, that light pipe is reflecting off of the air meniscus at the bottom of the eye, giving a reflex of the light in a different place. So that's one key detail that when you look at the image, you can tell that there's got to be air in this eye. But if you're comparing side by side, you can also see how in the far periphery here, superiorly, I can see a vortex vein. I can see 2 vortex veins actually, and you can't see that under fluid because you don't get as wide of a view. And one way to assess this as well is look at an anterior structure, such as the cortical spoke in the lens of this patient. It's bigger, it's more central under fluid. Under air, it's pushed more to the periphery because the air has created more of a peripheral view. So that's the neat part about air. Air is free, air is cheap. So we should use air to our advantage. So going to that example here, on the left is a fluid-filled eye, on the right is an air-filled eye. Look at I just kind of showed a very small glimpse of the superior periphery there, but sorry, that might be the inferior periphery. But look at the vortex veins and the inferior field of view. So if I rewind this video back here, look at that view back there. You can see all the way almost to ora serrata, versus a fluid-filled eye, you can't get that equivalent view. So I just wanted to give you an insight to what my typical operating day looks like, because I said I operate in the office. What does that look like? Does it look like a typical operating room? So this is not my typical setup. Here's a room that I've dedicated to cataract and retina surgeries, and there's the Zeiss ReSight system, right-hand light pipe, left-hand protractor, and I use a 3D heads-up display. So there's the image for vitrectomy that's in 3D. I'm wearing polarized glasses to view the image in 3D. There was a vitrectomy system and there's my office. So I'm at the end of the office with floor-to-ceiling glass so that patients can see what we're doing and appreciate that it's complex work. So a lot of times patients' loved ones are watching what we do. Now, this is a close-up view of those 2 major systems we talked about. First, we've been talking about the wide angle viewing system. So on the left here, you can see that lens is floating above the eye, and that's a wide angle viewing system. On the right, you'll see that there's a flat lens. If you can view the detail all the way to the eye, there's a flat lens on the eye. That's a contact lens for viewing the macula. And if you look at the microscope, I have pushed back. So I zoomed out of this picture because I pushed back the ReSight out of the way, because I don't need that for direct viewing through a contact lens. So that's what I wanted to highlight there. So contact macular viewing systems come in those three flavors that we talked about, which is it can be concave, concave, convex, concave, plano, concave. So these all offer different viewing experiences. On the far left, a plano concave view is going to give you a direct view. It's kind of an unaltered view of the retina. You're seeing it one for one. The concave lens is going to magnify the view, so it gives you a little bit more detail to the ILM, ERM, whatever you might be working on, the macular hole. Convex concave is a way to introduce a wider field of view. And we talked about this before, but unfortunately, you can only get so wide with this strategy. You can't get 100 degrees of view. You can maybe get 40, 45 at the most. So here's a typical contact macular view. Contact viewing gives you high resolution. So you can see this is very different than the vitrectomies that I showed you in the videos before. This is high resolution. There you can see that with blue stain, the residual, that's ILM that you're seeing actually. The residual ILM is clear, completely clear that you can see. And that allows us to differentiate surgical planes so that we can differentiate where is the ILM and ERM versus where is the retina. We don't want to grab the retina. Most commonly, these macular viewing systems are made of PMMA material. And PMMA is single-use disposable usually, and it's very light. It's got minimal material, so that adds to its stability. So that does not require an assistant to hold. You can just put it on the eye and it kind of stays there. So what about non-contact macular lenses? So that was a contact. Can you view the macula without putting a lens directly on the eye? So yes, you can. Here, this is with the Zeiss Resight. They're flipping from that yellow wide-angle lens to the green macular viewing lens. That's just like our slit lamp lenses, right? So in slit lamp, we use maybe a 90, a 78, 60. People use different ones, but we're in that range. And that's similar to the view that you might see in clinic, right? So that you can do. You can do a non-contact macular system. Most surgeons will say, well, why? What's the benefit? Because if I just put the contact lens on, I get a really beautiful view. In my opinion, I kind of agree that the stereopsis through contact viewing is better. The resolution is a little better. It just might be a little bit more convenient for you to be able to float above the eye and not have to touch the surface of the eye. So what are some challenges? We talked about a lot of good things about the viewing systems, but there are, of course, challenges. Here I'm showing you a video in the middle of surgery. My wide-angle lens has this opacity on it from processing. Steam sterilization process that we use left some residue on there, and it's interrupting my field of view. So here I am having to stop in the middle of clinic or middle of surgery and flush this lens and then clean it off so I can have a better field of view. There are other issues too. There's glare issues, and when you reprocess lenses, you lose an anti-glare coating. The clarity of that lens, I just showed you how to clean it. We change our view constantly. You saw air versus fluid, but sometimes we are under silicone oil. That can add a lot of challenge to viewing. Stability of these lenses, the ability to keep them in place without an assistant, that's a challenge. And then, of course, cost is very important. In different areas of the world, we need to factor in cost because we can't just have everything we want. We need to make sure it is feasible, financially feasible. So these systems are very expensive. We need to have a cheaper system. So what does the future hold? And I just want to give a quick shout out to my team at Yale. That's Lorenz, Nancy, and Bee, and they're working on developing a novel contact macular lens, which we think can give a big advantage in single-use, cheap, disposable, give a beautiful field of view. So those guys are going to be the future of retina surgery. Also, some other future projections that I think, so I do 3D viewing without microscope oculars. I think that as good as that is, the fixed screen, the 3D screen that I'm looking at, that's not the future. The future is going to be some type of floating screen or some type of screen that integrates with the environment. such as an augmented reality or virtual reality, where you can place different information in your real space. That is a part of viewing, right? This is relevant to surgical viewing because that'll increase our viewing potential. Guided surgical navigation, like pilots have, they put their augmented reality in the cockpit so they can overlay lots of instrumentation. We need to be able to do the same thing. We need better endoscopic view. So endoscopic vitrectomy, we haven't really talked about that, but it's not really taken off because the view is not so great. So we need better resolution and better ease of use of endoscopy. We need real time, all the time, SWEP source OCT integration. There is a product that's out to market right now by Bosch and Lomb with a collaboration with Heidelberg. And it's a beautiful product, it's very expensive, but at least they're introducing the concept of real time, all the time, OCT. And then a shout out to my colleague, Dr. Arroyo, who has launched Stitch platform. If you've heard, are a gamer or know of gamers, you've heard of Twitch. This is the surgeon version called Stitch. And in that sphere, surgeons can collaborate and share their surgical views. So we can all see each other's surgeries in real time and comment and collaborate, which is amazing. And then this is just a personal thing that I wanted to touch on very quickly is I think the future, one of the most disruptive technologies that the future holds for vitrectomy is where that surgery happens. And that's going to address a big cost issue and resource utilization issues. We don't have to be in the hospital. We don't need to be in the outpatient surgery centers. We can do this safely in the office. And we're going to produce the safety data that shows we can do all kinds of complex retinal surgeries, very highly sterile environment without doing the big cost of the construction of a hospital or a surgery center. And we can do it in the office, which keeps the surgeon where the patients are, where the clinic is. Very important. And that also gives breeding grounds for innovation, the way that I can collaborate with my team at Yale. And a shout out to Dr. David Almeida, who's introducing Case X, which is office-based retina surgery for research purposes, bringing vendors into the playground, bringing innovators into the entrepreneurs and et cetera, into the playground of that environment to take away all the barriers and the red tape and allow them in an environment where they can do prototyping and do new products. And like I said, I think this solves the access to care issue worldwide. Let's go through those polling questions, and I'm going to open it up to question and answer period. So let's queue up our second polling question, number 2, and re-engage with the audience. Okay, so we made some progress, a little bit of progress here. And then let's cue number 3. So what does air do to the view of the retina? We were showing it, did it give you a magnified view? Did it obscure the view completely? Did it make it wider? Did it not have any effect? Good. So the answer is it gives you a wider field of view. All right, so let's open it up to questions. Feel free to type them. How can you detect vitreous prolapse during cataract surgery if we don't see any iris irregularities and we don't have triamcinolone? So let's first talk about what we're referring to with iris irregularities and triamcinolone. So triamcinolone, or Kenalog for those that call it by that other name, can light up the vitreous strands. So if you have that, it's nice. Those crystals will attach to the vitreous and light it up so that you don't have to struggle to see. Iris irregularities, we're referring to pupil peaking. So areas where vitreous may run to the wound will probably put tension on that part of the pupil and cause peaking, meaning it's pulling on that part of the iris and you can kind of indirect. But what if you don't see that? If you don't see it, the best way is high magnification. So you're going to need to zoom all the way into the anterior chamber. And then dynamic viewing. Dynamic viewing means moving the eye. Typically, if we're under A topical block, which means the eye is not completely immobilized. 2-point fixation can do it, meaning second instrument plus primary instrument inside the eye can tilt it left, right, superior, inferior to see if we can view around it. You don't just have to look at the iris and the wound. You can also look at the capsule. The capsule may have similar peaking type properties, so you can see if the vitreous is coming through, putting tension on the posterior capsule where the tear is. But under high mag and dynamic viewing, you can sometimes see, yes, vitreous is clear, but it's not completely clear. You should be able to see something. If you have access to non-coaxial light, meaning not light that comes through the microscope, the light that can come from the side, that can help light up vitreous as well. Hopefully that helps a little bit. Just going through some of these to see which we can cover quickly. I'll just quickly touch on this question. What should we do if silicone oil comes into the anterior chamber in the presence of PI? So if a patient has a peripheral iridotomy and they have silicone oil in the posterior cavity and it comes forward, that's a tough situation. It's not causing any pressure issues or any visual issues for the patient. It can be monitored. If not, and it's causing issues, and you should be tracking endothelial cell count, because sometimes oil can cause damage to endothelial cells. You should aim to remove it. Removing it in clinic is tricky. Yes, it's possible to stick a high bore or large bore needle in the clinic under sterile conditions and try to suction it out. It requires a lot of force. So you can't just put it on a 5 cc syringe or a 1 cc syringe. It would require like a more than a 10 cc syringe to give enough back pressure. And usually an assistant needs to be next to you so you stabilize the needle while someone else is pulling on the plunger to remove the oil. But typically that should be done under sterile conditions in an OR. This question is, are non-contact lenses a bit inferior to contact lenses? That's a very nuanced question about what we've been addressing here, which is a contact lens system is always going to give you a better view because of neutralization of the corneal astigmatism or irregularities. It can allow light to pass through opacities better than in a non-contact system. So I would say, as far as viewing, as far as clarity of view goes, yes, non-contact lens may be a bit inferior to a contact lens, but what gives it the superiority and why it has so much popularity is the ease of the view. It does not require an assistant. It's a reliable way that you don't have to have something in the way. So contact lenses are also on the eye and they're bulky, and getting instruments in and out of the eye, manipulating the eye, that can be a little frustrating sometimes. So non-contact lenses take that out of the equation. So it's inferior when it comes to the actual view, but superior when it comes to the other factors that go into surgery. This is a good beginner level question, which is, when vitreous is removed, what replaces it? When is the right time to remove vitreous, and does vitreous have time to regenerate? Vitreous, once it's removed, is not going to regenerate. The vitreous you're born with is the only vitreous you get. And we have not really pioneered a vitreous substitute, an adequate one yet. There's many hydrogels that have been tried in development, but nothing that really works the same way that vitreous does. So when it's gone, we are infusing. So under those 3-port conditions, you saw there are 3, you know what 2 of those are for, which is a light and then the vitrector itself, or any secondary instrument, such as a forceps or a scissor or some other pick. But that third port, that is for infusion of fresh balanced salt solution to maintain pressure. So that is what fills the eye. Once the vitreous is gone, balanced salt solution fills and repressurizes the eye. And then I tell patients that in the hours after surgery, that actually is already being replaced naturally. You make aqueous through the ciliary processes to fill the anterior chamber. Aqueous will start to fill the posterior cavity. So you'll have the same fluid makeup of posterior cavity and the anterior. So the ciliary processes really take over in the hours after the patient goes home with balanced salt solution. I'm going to address these two questions back to back on office-based surgery, just because I'm very passionate about that field. And I want to make sure that that is answered in this. So one is how do you do office-based retina surgery? There's something called a surgery cube. Am I familiar with it? And then the follow-up question, another listener, is the risk of endophthalmitis, is it higher with office-based procedures? So let's talk about both of those. So the setup for office-based retina surgery really is no different than a surgery center or hospital. It should not be. It should look this exact same. Meaning when you walk in, if I blinded you and took you into the operating room and then unfolded the blind, minus the floor-to-ceiling glass of seeing that we're inside an office, it should feel the exact same. Of course, there are some differences that might not be palpable, or if you're in tune with your environments, maybe you can spot them. But in general, the conditions should look and feel the same as anywhere else. I am familiar with the surgery cube. Surgery cube just adds essentially laminar airflow and microparticle filtration. I don't do surgery cube. In my place, I use just standard HEPA filtration with MERV 13 or higher particle filtration, multi-stage. And then I also run air filters when we're not in the operating room to create a pseudo-sterile environment. And then is the risk of endophthalmitis higher after office retinal surgeries? The data does not show that. We have strong data on office-based cataract surgeries, and the data has shown that it's at par, or maybe even a little bit better. I hesitate to say better, even though the data shows it's better in office, because we need probably hundreds of thousands of cases. Right now, we have about 60, 70,000 cases in office under sterile conditions, and the endophthalmitis rates are better. That's a longer answer as to why that could be the case. But I think that surgeon involvement in office-based setting makes for a more sterile environment. So same goes for retina. I think the same will hold true for retina. Preventing lens fogging is tough. I mean, that is one of the challenges that we need to address, and it comes down to material and temperature differences. One of the ways that you can do it is to have the ambient temperature in the room be closer to the eye's temperature, the surface of the eye's temperature, so there's not a huge differential. Control the humidity in the room. You can put materials, people who do surgeons who do endoscopic surgeries, they deal with this with cameras that get inserted into the abdominal cavity or wherever. They have to put certain films or materials on the endoscopic camera to prevent fogging. I've employed the same strategy with contact viewing systems that does work. You can put this film over or a liquidy type substance over the lens to prevent fogging, but then it does degrade the view a little bit. So it's a balance. So that's one of the things that we have to address with future innovation. Well, thank you all for listening all over the world, and hopefully we learned a little bit today and shed some light on where we are currently and where we're going. It's my pleasure, my honor to do this.